Good morning and welcome to Annual Dialysis Conference. I'm really grateful to the organizers for inviting me to talk about this very important topic about catheters and home hemodialysis acceptance. I would have loved to be personally here like every other year, but due to my work transition, unfortunately, I'm going to miss that personal experience, but hopefully it is still useful to you. So as you have heard from Dr. Vacharajani about how great the catheters are and they can change the whole spectrum of home hemodialysis and make it great again, I would actually try to give you another perspective about whether or not central venous catheters boost home hemodialysis acceptance. I do not have any disclosures. So what I'm going to do is, first of all, try to analyze for you is access the main barrier to adoption of home hemodialysis. And I will discuss, can catheters really increase home hemodialysis use? I'll try to describe, are catheters safe for those on home hemodialysis, and propose how can actually we improve home hemodialysis utilization, of course, without using the catheters. So question one is access the main barrier to adoption of home hemodialysis? And that is why we are not getting enough people doing home hemodialysis. So let me point out to you this one article from IM Home study that looked at identifying major barriers to the adoption of home hemodialysis. This was a study of 522 responses from providers and patients. This was a online survey that was sent by FNKF and American Association of Kidney Patients. And if you will look at the findings, the top 3 patient perceived home dialysis barriers were the fear of doing home dialysis, limited space for equipment and supplies, and insufficient home-based support. Top 3 provider perceived home dialysis barriers were inadequate patient education, limited home-based support staff, mental health support and education, and insufficient experienced staff. Thematically, what they saw over and over again in this survey was that there was limited education, financial disincentives, resources were not there, there was high burden of care, delivery structure actually favored hemodialysis, there was perception of inequitable access, and the provider perception about the patients was also not very salutary, and limited patient and provider resiliency was there. So I would like to just point out, I didn't read catheter in any of these barriers. So looks like for the patients and providers, it was not the catheters. Now, just to give you a little bit more description of the real barriers to home hemodialysis, those are fear. When the patients and care partners are fearful, how can they do dialysis at home? What is the support? There is no supervision. Will they bleed out? Insufficient space for supplies and machines, lack of support. If something goes wrong, a lifestyle change, which is very hard for people to make, and dietary and fluid restrictions, which may actually be better in home hemodialysis if you do frequently. Those are still a concern. And there are cultural issues like a stigma of doing dialysis at home if somebody visits, and language barriers and unwillingness to do self-care, which is a huge issue as far as the United States goes. Then there are factors related to modality of home hemodialysis itself. The cost may be prohibitive for some patients and hospitals, although they are trying to give you financial incentives to promote home hemodialysis. There may be immigration-related issues, the insurance issues, the equipments may need troubleshooting, and the training is extremely important because you need to train patient and care partners how to cannulate and how to run the dialysis machine. So there are barriers there. And then there are barriers to home hemodialysis based on provider and patient both, is that there is lack of patient education. We have not done a good job of even teaching them vascular access types, or even choosing the type of renal replacement therapy. But about home dialysis, I mean, the education is practically not there. It's very little, and they don't know how to do pre-dialysis care and have shared decision making. So on the provider side, I would say we are also culpable because we have not really trained providers and not given exposure to the fellows to home hemodialysis as much as we should have given, and that is another barrier. And again, out on the whole list, the catheters are probably not there. So to summarize so far, the real barriers for home hemodialysis are in the minds and hearts of patients and in the poorly trained providers, not in the type of access. Yes, it is important to offer catheters to be patient-centric when there is role in their life plan, but it is really a pipe dream to imagine that those will increase home hemodialysis. We use a lot of catheters now, very little home hemodialysis. So how does that solve it? So the question too that I would like to ask is, can catheters really increase home hemodialysis use? So if you look at the catheter use in incident patients from 2012 to 2022, you will see that on the top, the incident patients, any catheter use was about 85%, catheter only was 74%. Nearly 80% of patients in the United States, as you can say overall, start hemodialysis with a catheter. That's a whole lot of patients who are starting with a catheter. I don't know where you will increase to 100% to try to increase home hemodialysis. That probably doesn't make much sense. And if you look at presence of AV fistulas, about 20% of people, 20 to 25%, have some type of AV fistula or graft, either maturing or matured at the time of starting dialysis. And when you look at the prevalent patients, even in those, the percentage of patients who are doing dialysis with a catheter has increased since 2017 from 18% to 24%. So yes, catheters are increasing. Show me the increase in home hemodialysis with that. In 2022, 59% of patients on in-center dialysis and 64% receiving home hemodialysis were using AV fistula. So actually, home hemodialysis was using more AV fistula than the catheters. And I will come back to that point again. So if you look at the home dialysis modalities, so PD and home hemo, the percentage of individuals with incident dialysis who did home dialysis, that increased in that decade from 2012 to 2022 from 8.5% to 14.5%. In 2022, however, the percentage of those who were incident dialysis patients who are doing home hemodialysis was a huge 0.4%, despite having 80% catheters. For home hemodialysis, the increase was from 1.5% to 2.4%, with essentially, during this period, essentially most of the growth being between 2018 to 2022, probably related to some financial incentives. So here are some points to consider. Almost 80 to 90% of US hemodialysis patients are exposed to catheters during their lifetime. So it's not like there is a lack of having catheters. If catheters were to favor home hemodialysis mortality, we should have had at least 20 to 25% of patients on home hemodialysis, not 1, 2, 3, 4%. Why the majority of patients, despite the availability of catheters, are not on home hemodialysis. There is not even room to increase more catheters. If we increase by 10%, go to 100%, and we get 0.2% increase in home hemodialysis, that's not going to be sufficient for our goals. So the lack of home hemodialysis is not due to non-utilization of catheters. I just wanted to make that point. Certainly due to some other factors that we need to start paying attention to. Let's consider one other thing. So is the catheter actually a good thing to have in home hemodialysis, and is that the predominant access? When you look at the home hemodialysis modality between 2012 and 2022, again, AV fistula was being used in 64.5% of those. Only a third were using a catheter, and some had AV graft. as well. So it seems like the fistula was not really a barrier. In fact, the catheter use was less. Yeah, maybe you could increase another 0.3, 0.4% by increasing catheters, but that's really not what our goal should be. Finally, I want to also talk about, are the catheters even safe for those on home hemodialysis? Let's look at the age-old paradigm, that things that we have been taught since the very beginning. So vascular access, when you consider that, an AV fistula is considered better than the AV graft, and AV graft is considered better than the catheters because of some very, very valid reasons. And let me try to give you and remind you why we do not try to use catheter in everybody, is because there is worse survival with catheter use, and hospitalization for bloodstream infection are more common with catheters, not with AV fistula or even AV graft. Yes, it is acceptable to have a CVC if it fits patient's life plan. There may be a niche area. There may be some people where we can take advantage of catheters. I don't want to completely discard all the catheters as a way of increasing home hemodialysis, but it makes sense to have not rely just on catheter to increase the home hemodialysis modality. Let's also face that catheters are cumbersome. When you want to care for a tunnel dialysis catheter at home, you have to make sure that the patient is very well trained in using the catheter. The dressings are done well, they are clean and dry, there is aseptic precaution, the area is clean, there's an emergency dressing kit. You have to have more than one, so in case you need to change between treatments, you need to have that available. And the catheters, you have to be careful not to let the air enter or the blood leave, because there is a very small percentage of people who do die of excess catheter-related bleeding. Make sure the scissors and sharp objects are away from your catheters, because there have been cases where catheters were accidentally cut. Not being able to take shower, having to use sponge bath during the catheters is also not very palatable. And then you have to use all the protections. You have to use a mask over your nose and mouth anytime you are opening the catheter. And again, you have to also look at the adequacy of dialysis, which may not be very good on catheters, although maybe we are able to do that, but that's another thing. And catheters are associated with inflammation and high EPO use. So catheters are not necessarily the best things. So let's finally think about, how can we actually increase home hemodialysis if it is not through using the catheters. So we're not going to use catheters, but we are going to still increase home hemodialysis. So let's look at the barriers. Let's look at the provider first. Are we training the physicians? We need to really mandate exposure to home therapies, have those questions in the board certification. We need to have more courses and trainings for physicians, and maybe there could be a third-year home dialysis fellowship, which actually teaches you PDs and home hemodialysis of the world. We need to also overcome difficulty in recruiting home hemodialysis nurses. We need to have cross-training of providers to do home dialysis. We need to increase the application of virtual care, which can provide some supervision. We need to improve education of the nurses, mandate their webinars. We need to improve their attendance in conferences, pay for education days. We need to improve patient awareness, teach patients, standardize training curriculum for patients and providers. For those who cannot do home dialysis because of some cognitive or physical barriers, assisted home hemodialysis may be something that can be offered. The patient fear can be alleviated with proper education. We could do community house dialysis. When I visited New Zealand, one of the dialysis unit was actually like a trailer. There was a dialysis machine in there. There was a lock, that there was a code. A patient could do, especially the homeless people, they could go there anytime and do dialysis themselves there at their choice. This was always available to them. Why can't, if New Zealand can do that, why can't we do that? Have the pods available for people to do dialysis at their own convenience. And then financial reimbursement to the hospitals, nursing homes, and dialysis units. We need to improve financial incentives, maybe do something with the Medicare to create cost savings that can be devoted to better areas, which will improve outcomes. And finally, regulatory authorities, CMS, can also make changes so there is no difficulty in reimbursement, and establish a national registry for home dialysis patients. So finally, I would like to say that there are certain targets for advocacy that we should actually start focusing on. We need to focus on the policymakers, the politicians, healthcare funders, and administrators, so that they can balance incentives for in-center and home hemodialysis and PD, and support for older people in the community. And increase in hemodialysis by engaging with patients and providing them this support and education. We need to improve local healthcare management through the nephrology societies and professionals, and educate them to change culture and grow the person-centered care and provide a holistic view of health and disease. And then we need to, of course, have home dialysis champions amongst the patients, providers, societies, suppliers in every group, so that they can stimulate in-home dialysis by highlighting the economic and patient advantages and these advantages to the healthcare systems. Overall, we need to develop that person-centered care in choosing modality through those measures. So finally, to summarize, the barriers to home hemodialysis are patient and provider factors with lack of education, not lack of catheters. Catheter use has not been shown to increase adoption of home hemodialysis, and in fact, people are using more fistula in home hemodialysis. Catheters are generally unsafe and inferior to arteriovenous access when it comes to the patient outcomes. Focus on removing barriers to home hemodialysis utilization. Need to focus on education, training, and incentives, not on increasing the number of dialysis catheters. I hope I was able to provide you another perspective, and I'm sure Dr. Vacharajani will have some other comments on this, but this is my view, and thank you very much for listening. Hope this was useful to you. I'll be happy to take questions at the end of the session. Thank you so much.